Hey class, in this module we're going to be talking about hypertension. I know it doesn't sound super exciting, but you are going to see a lot of patients with hypertension, and you yourself will probably have hypertension one day. It's a very common disorder, so let's dive in. Here are the learning objectives for this module. I'm not going to read all of them to you, but we're going to be talking about the pathophysiology of hypertension, the diagnosis of hypertension, and the management of hypertension. First, let's talk about why is high blood pressure so bad? Now, no talk about hypertension would be complete without a little history lesson about our 32nd president, Franklin Delano Roosevelt. He was diagnosed with hypertension in 1935, and back then we didn't treat it with medications. But by March of 1945, so 10 years later, he was showing signs of heart failure and kidney disease. In some of his radio addresses at the time, you can actually hear him wheezing, and he's unable to complete sentences because he's short of breath. In April 1945, he was seated for a portrait in his Georgia vacation home when he fell unconscious. His blood pressure was reported to be 350 over 195 at that time, and he died of an intracerebral hemorrhage. So why is high blood pressure so bad? It's the silent killer. People don't know they are sick because they don't have symptoms until it's often too late to fix things. In 2010, high blood pressure was the leading cause of death and disability-adjusted life years worldwide. And there is a relationship between blood pressure and cardiovascular disease that is linear, continuous, and independent of other risk factors. For each increment of 20 millimeters of mercury in systolic blood pressure or 10 millimeters mercury in diastolic blood pressure, there is a doubling in the risk of death from stroke, heart disease, or other vascular disease. That relationship was shown in this meta-analysis of 61 prospective studies. And you can see on the left that cardiovascular disease mortality increases in a linear fashion as your blood pressure goes up. And that same relationship exists with stroke mortality. Now, these are the complications of untreated hypertension. So like we've already talked about, heart disease is the biggest one. That can be in the form of coronary artery disease and myocardial infarctions. It's a big cause of left ventricular hypertrophy, and it can progress to congestive heart failure with either reduced ejection fraction or preserved ejection fraction. Untreated hypertension causes strokes, and that could be an ischemic stroke or a hemorrhagic stroke. It can also cause chronic microvascular disease that leads to cognitive impairment and dementia. Untreated hypertension also leads to chronic kidney disease and end-stage kidney disease, vascular disease like peripheral arterial disease and aortic dissections and aneurysms, and hypertensive retinopathy. So how does high blood pressure cause cardiovascular disease? When you have normal blood pressures and laminar blood flow, the endothelial cells of the blood vessels are happy. But when you have high blood pressure and turbulent blood flow, the endothelial cells are activated. So just that wear and tear and shear forces that you get from high blood pressure is going to activate these endothelial cells, which is going to make them more permeable and lead to more inflammation. And once these endothelial cells are activated, you get accumulation of lipoproteins like LDL in the vessel wall. You get migration of macrophages into the intima and adhesion of platelets. And these activated macrophages and platelets are going to recruit more smooth muscle cells, which proliferate and lay down extracellular matrix, making the intima thicker with calcified necrotic debris. All of this leads to arteriosclerosis, of which there are a few different flavors. Picture A here shows hyaline arteriolosclerosis, which affects small arteries and arterioles. The most common causes are long-standing hypertension and diabetes. And you see that there's this homogeneous pink hyaline thickening with luminal narrowing. These changes are caused by plasma proteins leaking across injured endothelial cells and by increased matrix synthesis by the smooth muscle cells in response to chronic elevated pressures. Picture B shows an example of hyperplastic arteriolosclerosis, which also affects small arteries and arterioles. And here we see the lesions have a concentric laminated onion skin thickening of the walls with some luminal narrowing. And that's typically seen in people with very severe hypertension or malignant hypertension. And then picture C shows an example of atherosclerosis, which affects large and medium-sized arteries. So this is what you'd see in ischemic heart disease, peripheral artery disease, and in the aorta and carotid arteries. And this is characterized by a large atheromatous plaques with fibrous cap. You can see it's full of lipids and extracellular matrix. Okay, so we've established that high blood pressure is bad because it causes arteriosclerosis. What actually causes high blood pressure? You guys remember good old Ohm's law, where blood pressure is equal to cardiac output multiplied by peripheral resistance. Cardiac output is equal to heart rate times the stroke volume, and the stroke volume is mostly determined by preload because of the Frank-Starling relationship. So the left ventricle will accommodate whatever blood returns from the venous system, and that will determine the stroke volume. And blood volume is regulated mostly through sodium homeostasis. Cardiac output is also affected by heart rate and contractility, which are regulated by the sympathetic nervous system through alpha and beta receptors. And peripheral resistance is regulated predominantly at the level of the arterioles. You guys remember Poiseuille's law, which states that resistance of a vessel is inversely proportional to the radius of that vessel to the fourth power. The radius of the vessel is regulated by neural and hormonal inputs. Vascular tone is a balance of vasoconstrictors like angiotensin II and norepinephrine, and vasodilators like prostaglandins and nitric oxide. Tissue pH and oxygen levels also affect blood vessels to accommodate local metabolic demands. So these systems are under pretty tight homeostatic control, but subtle derangements in things like sodium homeostasis and vascular tone can lead to pathologically high blood pressure. And where is sodium regulated? Mostly in the kidneys. The sodium is reabsorbed throughout the nephron, but is most tightly controlled at the epithelial sodium channel, ENaC, which is regulated by the renin-angiotensin-aldosterone system. So excessive RAS activity will lead to increased sodium absorption, which increases blood volume and therefore blood pressure. So normally if you take in a bunch of sodium, like you go eat a bag of Doritos, that's going to suppress renin, which will suppress angiotensin II and aldosterone, which leads to vasodilation and natriuresis, or urine sodium excretion. But in some people, RAS remains active at higher levels of sodium intake, so that they are not excreting all the sodium that they are taking in. And this trait is often called salt sensitivity and is most likely inherited. So while people can be arbitrarily divided into dichotomous groups of salt sensitive and salt resistance, the reality is that blood pressure response to sodium intake occurs across the spectrum. So the vast majority of hypertension, about 90%, is called essential hypertension or primary hypertension or idiopathic hypertension. And this type of hypertension results from interaction of multiple factors, both genetic and environmental. So family history is a big predictor of hypertension. There's large genome-wide associated studies that point to more than 60 genes that can contribute to hypertension with polymorphisms that affect RAS, sodium homeostasis, and vascular smooth muscle cells. But environment risk factors also play a huge role. So diet, especially excessive sodium intake and low potassium intake, are a big contributor. But tobacco use, obesity, sedentary lifestyle, air pollution, socioeconomic status, and even systemic racism have been identified as risk factors for hypertension. About 10% of hypertension is secondary to another disease process. We call that secondary hypertension. One of the most common causes is primary hyperaldosteronism, but there's other rare causes of secondary hypertension like pheochromocytoma, thyroid disease, Cushing's syndrome, etc. Renal disease is also a big cause of secondary hypertension, both renal parenchymal disease and renal vascular disease like renal artery stenosis. There's a bunch of different medications and drugs that can cause hypertension, and then obstructive sleep apnea is a very common cause of secondary hypertension, whereas something like an aortic coarctation can cause secondary hypertension but is pretty uncommon. So when should you suspect that somebody has secondary hypertension, right? Like most of the patients you see are going to have essential hypertension. So how do you identify those 10% of patients that actually have a secondary disease process going on? So you want to suspect it when they're under the age of 30 at the onset of their hypertension, or if it's an abrupt onset. If they had previously well-controlled hypertension that's suddenly worsening, or if they have resistant hypertension. So they're on 3 different hypertensive medications, one of which should be a diuretic, and they're still having high blood pressures. Also, if you see disproportionate end organ damage for the degree of hypertension, or an accelerated or malignant hypertension, which we'll talk more about, or if you see unexplained or excessive hypokalemia, you should think about potential endocrine causes like primary hyperaldosteronism. Now, a small percentage of people with hypertension will actually have a rapid rise in blood pressure that, if they don't treat it, can lead to death in just a couple of years. And this type of hypertension, malignant hypertension, is characterized by very severe pressure elevations like systolic blood pressures in the 200s or diastolic blood pressures over 120, and often presents with renal failure and hypertensive retinopathy. And it can develop in people who were previously had normal blood pressures, but usually it's going to happen in someone who had pre-existing hypertension. Now, this is a fundoscopic exam of a gentleman that presented to the emergency department with 1 week history of blurred vision and headache, and his blood pressure was 250 over 170. And this exam shows grade 4 hypertensive retinopathy with disc edema in both eyes. And he had flame-shaped hemorrhages, which are pointed at by the arrowheads, and heart exudates, which are pointed at by the arrows, and cotton wool spots shown with the asterisks. And so he was admitted to the hospital and started on blood pressure medications, and fortunately was able to actually recover most of his vision. So like we said, primary hyperaldosteronism is one of the most common causes of secondary hypertension, and about 20% of patients who have resistant hypertension actually have too much aldosterone. And so pretty big group of people, and aldosterone is pretty toxic to the tissue, so they have a higher risk of heart disease, kidney disease, and strokes because of the excess aldosterone. And it's important to identify these people because it's very treatable. So you can put them on a mineralocorticoid receptor antagonist like spironolactone, or you can actually remove their adrenal gland, or if they have like an adrenal nodule that's cranking out aldosterone, they can get that treated surgically. So who should you test for primary hyperaldosteronism? People with early onset hypertension, people with resistant hypertension, so they're on 3 blood pressure meds, one of them is a diuretic, still have uncontrolled blood pressure, or if they have hypertension with unexplained hypokalemia, or if they're get a CT scan for some other purpose and you find an adrenal lesion, they should be tested for this. So if you have a patient where you're suspecting primary hyperaldosteronism, the first thing you want to do is send a plasma aldosterone concentration level and a plasma renin activity. Now, if the adrenal glands are pumping out aldosterone, you'd expect that aldosterone level to be pretty high, and plasma renin should be suppressed. So plasma renin levels will be low. And so the ratio of plasma aldosterone concentration to plasma renin activity will be pretty high. Whereas if you have a patient with renal artery stenosis, they're going to have poor blood flow to the kidney, and so their plasma renin activity will be quite high, and that will drive a high plasma aldosterone concentration, but the ratio will still be in proportion. Then there's another category of endocrine causes of secondary hypertension, caused by other types of hormones and steroids, like in Cushing's syndrome, and that's where you might have very elevated cortisol. That's actually going to cause a low plasma aldosterone concentration and a low plasma renin activity. Renal artery stenosis is an important cause of secondary hypertension, and it's usually going to be caused by atherosclerotic disease, about 90% of cases. And you would think if someone had a large atherosclerotic plaque that was obstructing blood flow to their kidney, that they would benefit from balloon angioplasty and stenting that artery open. But actually in trials where they've compared medical therapy to revascularization, there is no proven benefit. And so most of these patients are going to be treated with just blood pressure medications, definitely RAS blockade, And then you want to manage their atherosclerosis with a high-intensity statin. If they're smoking, they need to stop doing that. And then some patients need antiplatelet therapy and glucose control if they have diabetes. If you're managing all of that and their blood pressure is still really high, then you would consider revascularizing at that point. There's non-atherosclerotic causes of renal artery stenosis that are less common. Fibromuscular dysplasia and Takayasu arteritis. Typically going to see those in younger women. These can be managed medically or with revascularization as needed. Obstructive sleep apnea is a very common disease caused by recurrent collapse of the upper airways during sleep. This leads to hypoxemia and sleep disruption. And in folks with resistant hypertension, it's pretty common. And you treat obstructive sleep apnea with continuous positive airway pressure, but no one has actually shown that using your CPAP will improve your cardiovascular outcomes. And that may be due to the fact that it's just really hard to use CPAP with perfect compliance. There's a lot of medications and drugs that can cause secondary hypertension. Alcohol is a very common cause. And then you have your amphetamines, antidepressants, antipsychotics. Always want to talk to your patient about over-the-counter stuff like caffeine, decongestants. NSAIDs are very common. Oral contraceptives can also cause secondary hypertension. And then people on long-term steroids, if you're doing a short course of steroids, no big deal. But if you're on steroids long-term, you are going to develop hypertension. And then people who've had organ transplants that are on cyclosporin and tacrolimus will also start to develop hypertension over time. And then make sure you ask your patient as well about recreational drugs like cocaine and meth. Okay, so what is the optimal blood pressure? For many years, we treated patients if their blood pressure was over 140 over 90. And the goal was to just have them less than 140 over 90. And then the SPRINT trial came out, and their theory was that patients would do better if we got them to less than 120 for systolic blood pressure. So that was the intensive treatment arm. And I just want to point out that Dr. Alfred Chung is a nephrologist here at the University of Utah, and he was part of the research group who did the SPRINT trial. And the SPRINT trial actually ended early because they found that the primary composite outcome was happening lower rates in the intensive treatment arm, and that all-cause mortality was significantly lower in the intensive treatment arm. This was at the expense of more hypotension, syncope, electrolyte abnormalities, and acute kidney failure in the intensive arm. But this was a landmark trial that really shifted the way we manage blood pressure. So after the SPRINT trial was published a year later, we got these updated hypertension management guidelines from the American College of Cardiology, the American Heart Association, and a whole bunch of other organizations. Then in August 2025, we got new hypertension guidelines, which are basically the same as the 2017 guidelines with a few minor updates. One of the things that the 2017 guidelines did was create new definitions for hypertension, and those definitions are preserved in the 2025 guidelines. So normal blood pressure is still considered less than 120 for systolic and less than 80 for diastolic. Then they came out with this new category called elevated blood pressure, which is systolic of 120 to 129 with the diastolic still under 80. And this isn't considered a disease, but they do have high blood pressure, and you should keep an eye on them. Stage 1 hypertension is systolic of 130 to 139 or diastolic of 80 to 89. Stage 2 is a systolic blood pressure of at least 140 or a diastolic blood pressure of at least 90. So you should memorize these numbers. They are testable, and you want to know what stage of hypertension your patient has because that could change the management. I also want to point out that they recommend you test blood pressure on at least 2 occasions to confirm that the blood pressure is high. So if you have a patient in clinic and their blood pressure is 138 over 85, have them come back in a week or 2 so that you can confirm it's actually high before giving them the diagnosis of hypertension. Here's a table from the 2025 guidelines showing the prevalence of hypertension in the United States based on those definitions. You can see that nearly 50% of adult men in the United States have hypertension and nearly 44% of adult women. You'll also notice that the prevalence of hypertension increases with age. So when you get to be 80 years old, almost everyone has hypertension. You'll also notice that there are discrepancies in race. 57% of non-Hispanic black men have hypertension versus 47% of non-Hispanic white men. All right, so what is the correct way to measure blood pressure? So this is actually in the hypertension guidelines. They have very specific instructions for how to correctly measure blood pressure. And you will find that when you are in clinic that it's rarely actually done correctly. So this is one way that maybe you can have a positive impact on your clinic, is try to encourage them to measure blood pressure correctly. But the first thing is to have the patient relax and sit in a chair, feet on the floor, back supported, and they say for at least 5 minutes, which, in a busy clinic, probably not going to happen. They should also avoid caffeine, exercise, and smoking for at least 30 minutes. And you shouldn't talk to them at all while you're measuring their blood pressure. And you want to remove any clothing that's covering the location of the cuff, so pulling a shirt sleeve up or taking off a jacket. And you need to make sure that you're not measuring them while they're sitting or lying on the exam table. So you want to support the patient's arms, so have it like resting on a desk. You need to position the middle of the cuff on the patient's upper arm at the level of the right atrium, which would be about the midpoint of the sternum. And you want to make sure you use the correct cuff size. So if you're using a small cuff, it's going to cause falsely high blood pressures, and a large cuff could cause falsely low blood pressures. If it's your very first visit, you should check blood pressure in both arms, and then whichever arm has the higher reading, you should use that one in the future. If you're going to do repeat measurements, you want to wait a minute at least in between. And then when you're deflating the cuff, a lot of people deflate it too quickly. You want to make sure you're doing about 2 millimeters of mercury per second. Here's a nice graphic from the 2025 guidelines that summarizes all of those recommendations for blood pressure measurement. Okay, so based on the very specific guidance for checking blood pressure, what's wrong with this picture? Well, this guy is sitting on an exam table. He should be sitting in a chair with his back supported. Also, he needs his arms supported. What about in this picture? So she has the cuff over her sleeve, right? So that's a big no-no. Her arm is supported though, and she is sitting in a chair. So really the main thing here is she needs to remove that sleeve. And then in this picture, she needs her arm supported, and it looks like they're having a good time. They're talking, they're joking, and that is not allowed when you're measuring blood pressure. Okay, so that's the basic way to measure blood pressure. You can also use automatic blood pressure machines, and these are great because they'll do sequential blood pressures on a patient who's sitting alone in the room, and it'll measure 3 to 6 times over 4 to 7 minutes and then give you an average blood pressure. So it's more accurate. It's going to reduce the incidence of white coat hypertension, which is when the patient's blood pressure is high at the doctor's office but normal at home. So sometimes when patients come in, they're a little nervous, a little anxious. You check their blood pressure, it's high. You put them on one of these blood pressure machines. It cycles through and takes it like 5 more times, and usually your blood pressure levels come down 10 to 20 points. You can also do ambulatory blood pressure monitoring. These are 24-hour portable devices that the patient wears just throughout the day and even when they're sleeping. And so it's going to cycle and check their blood pressure like every 15 minutes during the day and every 30 to 60 minutes at night. You might do this in someone who has really variable blood pressures, in someone who you think just has white coat hypertension, or in someone who has masked hypertension. And that would be someone who has normal blood pressure at the doctor's office, but you're pretty sure that their blood pressure is high most of the time. And maybe you think that because they have end organ damage like left ventricular hypertrophy. You can also use this for nocturnal hypertension testing, resistant hypertension, in people with pregnancy. All right, now let's talk about the management of hypertension. So if you have a patient that you're diagnosing with hypertension, it's a good idea to get some basic lab studies. So the guidelines recommend that you check a blood sugar. You're looking to see if they also have diabetes, get a complete blood count, fasting lipid profiles so that you can figure out what their cardiovascular disease risk is. And then your basic metabolic panel with the creatinine, sodium, potassium, calcium. Hyperthyroidism and hypothyroidism can cause secondary hypertension. Not super common, but it's pretty easy to grab a TSH, and so guidelines do recommend that. And you want to get a urinalysis too to make sure there's no blood or protein in their urine. And then an electrocardiogram could show you signs of any heart disease. Once you have basic labs, you can calculate your patient's 10-year risk of cardiovascular disease using the Prevent online calculator. So the Prevent score was developed in 2023, and the 2025 guidelines recommend using this calculator now to estimate risk. And you can see that it includes questions about blood pressure, cholesterol, BMI, kidney function, diabetes, and smoking status. You can also enter information about the patient's zip code to further refine risk assessment, which is kind of wild. Okay, after you've diagnosed someone with hypertension, you've gotten their baseline labs and calculated their cardiovascular disease risk, what's the next step in management? So this algorithm is from the new 2025 guidelines, and I like it better than the 2017 algorithm. It's a little more straightforward. Basically, the first question is, does the patient have stage 2 hypertension? If yes, then you start blood pressure medications. If their blood pressure is less than 140/90, but they have stage 1 hypertension, the next question is, do they have pre-existing cardiovascular disease like coronary heart disease or prior stroke? Then start blood pressure medications. If not, the next question is, do they have diabetes or chronic kidney disease or a 10-year prevent score of at least 7.5%? If yes, then start blood pressure medications. If not, then you can recommend lifestyle interventions and have them come back in 3 to 6 months. And if at that point their blood pressures remain above 130 or 80, you should start blood pressure medications. So here's a table from the guidelines with those same recommendations. So if blood pressure is over 140/90, start medications right away. If they have cardiovascular disease, chronic kidney disease, diabetes, or their 10-year CVD risk is at least 7.5%, start medications. If none of those things, then start with non-pharmacologic interventions, also known as lifestyle interventions, for 3 to 6 months. So here's a table showing the best proven non-pharmacological interventions. So weight loss is a big one, healthy diet. The DASH diet and the Mediterranean diets are the ones that have been studied the most. Both of them can lower blood pressure. But whatever your diet is, it's good to have lower sodium and higher potassium. So they recommend 3,500 to 5,000 milligrams of potassium a day and less than 1,500 milligrams of sodium a day, which is very difficult to do. I also recommend physical activity, so you want aerobic exercise and resistance training, and then moderation in alcohol intake. So you don't have to stop drinking alcohol, but if your patient's drinking more than 2 drinks a day and they're a man, or more than 1 drink a day and they're a woman, then you should ask them to cut back on how much they're drinking. Once you've decided that your patient needs medications, then you need to decide if they need 1 or 2. And that's pretty easy because patients with stage 2 hypertension should start 2 medications and patients with stage 1 hypertension should start 1. And if you are going to start 2 medications, preferably you should prescribe a combination pill to make it easier for your patient. These are your first-line agents, so thiazides and thiazide-like diuretics, ACE inhibitors, angiotensin receptor blockers or ARBs, and calcium channel blockers. So these are your options for first-line agents. There are other blood pressure medications that you can use. These would be second-line agents, so not the first drug you want to reach for, but beta blockers, beta and alpha blockers, loop diuretics, aldosterone antagonists like spironolactone, alpha blockers like doxazosin, alpha 2 agonists like clonidine, and then your vasodilators. Can be used, but like I said, these are second line agents. So how do you decide which drug you're going to pick? Well, for most patients, it really doesn't matter. You just want to pick a first line agent. Um, and so, for me as a hospitalist, I don't see patients in clinic for their hypertension. And so if I am going to start someone on a medication for hypertension, I usually just go with amlodipine because I don't need to check any labs or follow up or anything. I can just say, here's some amlodipine, follow up with your primary care doctor. But you do want to think about things like half-life, right? So if you're going to start someone on a thiazide diuretic, you should probably start one with a longer half-life. You'll get better blood pressure control. So chlorthalidone is better than hydrochlorothiazide. And then for the ARBs, telmisartan, irbesartan, olmesartan all have longer half-lives than losartan. For some reason, losartan seems to be the most commonly prescribed ARB, but really you probably want to use one with a longer half-life. And then think about side effects. So if someone has really severe gout, you probably don't want to start them on a diuretic right off the bat because that can actually raise their uric acid levels and exacerbate their gout. Whereas an angiotensin receptor blocker actually increases uric acid excretion, so maybe that's a better option in someone with gout. If someone has pretty severe peripheral edema already, maybe you're not going to grab a calcium channel blocker as your first choice. And then ACE inhibitors very commonly cause cough. And so I usually don't pick those first line just because you're going to have to switch to an angiotensin receptor blocker in the future. So I'll usually just start with an ARB. You also want to think about comorbidities. So if someone has ischemic heart disease, then those people will benefit more from like beta blockers and ACE and ARBs. If they have angina, beta blocker is a good anti-anginal therapy. So you want to kind of max them out on their beta blocker. And then if they still have angina, the guidelines recommend adding a dihydropyridine calcium channel blocker like amlodipine. If the patient has heart failure with reduced ejection fraction, there's pretty good evidence for guideline-directed medical therapy with a beta blocker, an ACE, ARB, or ARNI, and a mineralocorticoid receptor antagonist. All of those things are going to help that person's blood pressure. And it's important to avoid calcium channel blockers like diltiazem and verapamil because they actually have a negative inotropic effect on someone who already has a weak heart. You don't want to mess with those drugs. And then if the patient has albuminuria, either from chronic kidney disease or diabetes, you want to put them on an ACE inhibitor or an ARB. And it doesn't really matter which one you pick. They're both going to treat albuminuria. All right, so we're starting patients on medications. What is our actual blood pressure target for people with hypertension? The guidelines recommend that for people with elevated cardiovascular disease risk, you reduce blood pressure less than 130 for systolic, with encouragement to achieve systolic blood pressure less than 120. So the recommendation is less than 130, but try to get them under 120 if you can, like in the SPRINT trial. The goal for diastolic blood pressure is less than 80. For adults without elevated cardiovascular disease risk, they say that a goal of less than 130 over 80 with encouragement to less than 120 may be reasonable, but that's a class 2B recommendation, meaning the evidence isn't as good. All right, now let's talk about hypertension in pregnancy. So this is one of the leading causes of maternal and perinatal mortality worldwide. The U.S. Preventative Service Task Force recommends that you screen for preeclampsia by measuring blood pressure at every prenatal visit. Preeclampsia can occur in about 4% of pregnancies and accounts for about 9% of maternal deaths in the United States. And it's associated with an increased risk of preterm delivery, intrauterine growth restriction, placental abruption, and perinatal mortality. So there's some different flavors of hypertension in pregnancy. You could have someone that already was diagnosed with hypertension before they got pregnant. You could have someone with gestational hypertension who develops hypertension after they become pregnant, and the cutoffs for that is 140 over 90, and they can't have any protein in their urine. If you have somebody with a blood pressure over 140 over 90 and it's after 20 weeks gestation and they have protein in their urine, then we call that preeclampsia. And if their blood pressure is really high, like over 160 over 110, and it's after 20 weeks gestation, they have proteinuria, and they have some of these severe features like thrombocytopenia or kidney disease, or liver disease, or headaches. We call that preeclampsia with severe features. And then there's a special case of preeclampsia called HELP syndrome, where they actually develop hemolysis, acute liver injury, and low platelets. And then the worst form is eclampsia, which is hypertension plus seizures, or preeclampsia that progresses to having seizures. So the best treatment for preeclampsia is delivering the child if they're at term. But if not, and it's mild, you can treat them just with blood pressure control. If they have severe features, they might need to be admitted to the hospital for treatment with things like magnesium, which can help prevent seizures. The guidelines recommend specific medications for hypertension in pregnancy, including labetalol and nifedipine. The 2025 guidelines also added new medications that should be avoided in pregnancy. So in addition to ACE inhibitors and angiotensin receptor blockers, they've added atenolol, renin inhibitors, nitroprusside, and mineralocorticoid receptor antagonists. The 2025 guidelines also added a recommendation to prescribe a baby aspirin for women with gestational hypertension to reduce the risk of preeclampsia. And they also added thresholds for urgent and chronic treatment of gestational hypertension. All right, and last, we're going to talk about hypertensive emergencies. So this is if somebody has a blood pressure over 180, over 120, plus they have some kind of end organ damage. So that might be that they have hypertensive encephalopathy, which means they come in really confused and out of it. They could come in with strokes, either ischemic or hemorrhagic. They could come in with a heart attack or with chest pain, or they could come in with acute left ventricular failure with flash pulmonary edema, like they can't breathe because their lungs are filled up with fluid. Aortic dissection is a specific or is a special cause of hypertensive emergency. Acute renal failure, eclampsia, and then it can even cause a microangiopathic hemolytic anemia, and like we've already talked about, papilledema and retinal hemorrhage. So in adults who are having a hypertensive emergency, the guidelines recommend that we admit them to an ICU for continuous monitoring and to give them IV antihypertensive therapies. Now, if they have a very specific condition like an aortic dissection, eclampsia, or pheochromocytoma, you want to bring their blood pressure down pretty quickly. So you're trying to get them less than 140 in the first hour. And for aortic dissections, you're trying to get them less than 120. But if they don't have a specific condition like that, you don't want to bring their blood pressure down too quickly because you don't know how long their blood pressure has been that high. Their brain might need that perfusion pressure. And so if you drop them too fast, you can actually cause like a watershed stroke. So these are your IV medications that you can use for hypertensive emergency. Nicardipine is a short-acting calcium channel blocker. You have your nitric oxide donors like nitroprusside and nitroglycerin. Hydralazine is a vasodilator. Esmolol and labetalol are beta blockers. Labetalol has some alpha blocking too. Phentolamine is a pure alpha blocker. Phenoldiprem is actually a dopamine agonist. I haven't really seen it used very much, but it is something you might see on board exams. And then enalaprilat is an IV ACE inhibitor. Now, depending on what kind of emergency they're having, there are kind of preferred drugs that you might use. So if someone's having an aortic dissection, the preferred drug would be to use a short-acting beta blocker like esmolol or labetalol, because patients who get vasodilators, if you bring their blood pressure down, it actually will cause reflex tachycardia, which can actually worsen a dissection. And so you want to block them first with a beta blocker if you're going to give someone a vasodilator. If someone's coming with acute pulmonary edema from like acute heart failure, then you want to avoid beta blockers because of the negative inotropy and use like vasodilators like nitroglycerin or nitroprusside. Prolonged nitroprusside can lead to cyanide toxicity, which is a step 1 favorite. Acute coronary syndrome, you want to treat them with beta blockers and nitroglycerin. Acute renal failure, you want to use calcium channel blockers if possible. And if someone's coming in with eclampsia or preeclampsia, again, you're going to use the calcium channel blockers and labetalol. You can use hydralazine, but hydralazine is pretty unpredictable. You might bottom out their blood pressure. and so we usually don't use hydralazine. And then a pheochromocytoma is kind of the preferred drug for that would be like phentolamine, the alpha blocker. Now, what if the blood pressure is over 180 over 120, but there's no end organ damage? This used to be called hypertensive urgency, which was a terrible name because it still sounds like a crisis. People would go to their primary care doctor for something else and they would get a routine blood pressure check and it came back really high. So everyone would freak out and send the patient to the emergency department for hypertensive urgency. And then the ER would try to admit the patient to the hospital. Then people would start a bunch of blood pressure medications. And what we found is in those patients, they actually had worse outcomes if their blood pressure regimen was intensified in the hospital, which is counterintuitive. Now the 2025 guidelines are calling this severe hypertension, which I think is a much better name, and Drake thinks so too. So what do we do for severe hypertension? Well, if the blood pressure is over 180 over 120 and there's no evidence of end organ damage, the goal is to bring down blood pressure over hours to days. They don't need to be admitted to the hospital for this. Find out if the patient is already prescribed medications for hypertension. Maybe they just forgot to take their meds. Maybe they ran out of meds and they need a refill. Maybe they're taking their meds and they need an additional medication. Maybe they need a workup for secondary hypertension. The 2025 guidelines added a recommendation to not use IV or oral antihypertensive medications in patients hospitalized for non-cardiac conditions with a blood pressure over 180 over 120 without organ damage. So it's very common for patients to be admitted for something else like pneumonia or a hip fracture, and the nurse pages you that their blood pressure is over 180 over 120. We used to give those patients IV medications like hydralazine or labetalol, but now we know that that can actually cause harm and does not benefit the patient. So it's better to do nothing. You still want to evaluate the patient, make sure they aren't in pain or anxious or withdrawing from something. And if they're on home blood pressure medications, then you should restart those. But don't give IV hydralazine, please. If you do, I will hunt you down and make you watch this video again. All right, we made it to the end of the talk. Covered a lot of ground there, but hopefully you're feeling more comfortable with diagnosing someone with hypertension and knowing where to start for treating hypertension. So thank you for your attention.